Thank you for watching our e-brochure. Let me introduce our guest today, Professor Scott from Sweden and Dr. Lam. Let's talk about the cells mark.
So maybe I start off with a very simple question first to Professor. What is TK1 actually?
TK1 is a molecule, compound, which is very important for cell to grow. And in fact it is what we call an enzyme, maybe that is too much, but this is a molecule that can activate other molecules in the cell. And when the cell decided to grow, they will start to produce this molecule we call TK1. The real name is thymidine kinase 1, but it's too much, so we call it TK1. It's simple.
Yeah.
So it's very important for the growth. So that's why we use it as a marker for growing cell. So when this molecule TK1 started to increase, then we know, here we have growing cell. Both tumor and normal.
I see. So is it difficult to be found? How do you find it throughout all these years?
You mean how
From
from
the role,
beginning?
from
the beginning.
from the lab to the now to the application.
Oh yes, yes. As I said yesterday meeting that this TK1 was discovered 1951, very long time ago.
Yeah.
Because at that time, researcher was very interesting to understand the mechanism in growing cell. And TK1 is very close to what we call DNA. Sometimes we call DNA chromosomes. Sometimes we call it gene. It's the same, but it's different name. And then people started to do a lot of basic investigation about this TK1 for many, many years. And now we have more than 3,000 publications just about this molecule, basic. And we have about 500 publications generally close to clinics application, and about 250 close to cancer tumor. So it's a very well known molecule. We know almost everything about it. But it has takes time. Around 1960 it was suggested to use it as a marker for proliferation, for growth. And it takes another 25-30 years before we could have it as a commercial test. You know, from ideal to application, long time, almost the whole life.
I see.
So slow.
In the past, we did know another enzyme called LDH, lactate dehydrogenase, which also reflect the degree of metabolism in the body.
Yes.
How we compare between the two? For example, I know LDH is not a very sensitive or specific marker, but it has still some role, for example, in lymphomas and also probably in germ cells tumors. How we compare between the two?
You know, every cell in the body have a metabolism. They do something. They produce energy so that other molecules can do what they shall do. But TK1 is very, very specific related to growing cell, because you can have cell which have a lot of metabolism, but they are not growing. They don't run the DNA synthesis. They don't double the chromosome number, but they are still alive and very active.
I see.
So you know, we differ between what we call differentiated cells. So this is cell, for example, nerve cells, muscle cells. They are differentiated to do some specific, but they are almost no growing.
Yeah.
And then you have growing cell, and that job is to create a new cell. So TK1 reflect growing cell, and you know, the characteristic of tumor cell is they are growing
Mm.
from 1 to 2 to 4 to 8. Suddenly you have like this. You know, you have maybe seen it many times, big cell.
Yeah.
So this is the what we call characteristic of a tumor cell. They also have a lot of metabolism, and that one you can measure with other enzymes. I mean, they produce energy. So TK1 reflect growing cell, and other enzymes reflect metabolism.
I see.
And both are very, very important. And I recommend it that we use a number of different markers together.
Okay. To get a whole picture.
The whole picture.
Yeah.
And somebody set up, as say, maybe 10, 12 different markers. So this is very important. One molecule cannot solve all problems.
Okay.
We need a battery of markers.
I see. I guess another question that is commonly being asked is that, for example, we have many different serum tumor markers. For example, CEA, or say 15.3.
AFP, you talked yesterday.
Yeah, AFP, of course. Alpha protein, for example. How we compare between the two? I mean, how will you compare between TK1 and these, I would say, this basket of tumor markers? What are their difference in terms of applications?
Yeah. The other markers are not very related to proliferation, to growing. So this is quite different. But still, they are very useful in another way. So we recommend it. Use TK1 in combination with CA, AFP, whatever you have. You
Yeah,
a lot
we
of
have
names,
a
we
full
don't have to
panel.
repeat it. So this is what we say, because they reflect different things. We have compared TK1 with AFP, CA, and other markers in serum and found they are not correlated to each other. And that surprised me when we found. So that means that when TK1 is high, they are very low. So I started to think, why could it be like that? And then it must be that these markers, TK1, AFP, they reflect different properties of tumor cell.
I see.
And we shall not exclude them, we shall use them, as you said, then we have a more full picture and knowledge about the tumor.
Yeah, that's very important to note.
Yes.
And do we have any studies, for example, in using TK1 in healthy population, for example, as a sort of screening tool? Have we had any clinical data to use this TK1 in healthy population? Healthy population. Yeah, in terms of detecting early tumors, for example.
Sure. We have tested more than 160,000 healthy people. Also from health screening. 160,000. That is another big study, and more is coming in. Sure, and we found that about 1-3% has higher TK1 level. Most of them have very low TK1. Thanks or congratulations to these people, they are not in a very high risk. And those ones with higher TK1 value, we have a follow-up about 12 years now.
12 years.
12 years. And found that these with a higher TK1 value, they have about 3 to 5 times higher risk to develop malignancy. Also they develop tumors. So this is very clear, and I said many times when we started to find out that TK1 can be used in health screening to find people with tumors and people in the risk to develop tumor. When we started to talk about that about 10 years ago, I said, no, it will not work. Because I know, found markers for malignancy in health screening is very difficult.
Yeah.
There is hundreds and hundreds of research groups who think, okay, I will test my marker, and they found it's very, very difficult. So I said from the beginning, I don't believe it. Really, I don't believe it. But then we started to do preliminary studies, and we increased. And to my surprise, yes, we can use TICO1 for early discovery of tumor. And I was so happy. I remember my colleagues sitting there when we started to analyze the first 11,000 cases. I said, my God, TICO1 is a good indicator. And I remember, my hair like this, because it was some exciting moment. I mean, we have spent 25, 30 years to investigate this marker, and most of the time you cry,
I see.
Yeah. This is research.
The life of a scientist.
But first you have a good idea. No, it doesn't work. Good idea. No, it doesn't work. And suddenly we have something here. So then we continue. First we had 11,000 cases we published, 2008, I think it was. And then we continue. So now we have 160,000 cases we have investigated.
Okay.
So I'm absolutely sure we have a good market here. And so what we have to do now is to go to people like you and other people. Please help us to investigate it.
And we always say that early detection saves lives, because whenever we can detect a tumor at an earlier stage, there will certainly be a higher chance of cure by resecting them or by giving appropriate treatment. I would say out of the 2 to 3% that you have mentioned that with raised TK1 level, how many of them are actually detected with a tumor with an early stage?
Yes, not 2 and 3%. No, because TICO1 also not only discover people with the early tumor, but in the risk to develop. That means they maybe not develop tumor, but they have a risk, and we don't know which one will develop. So how many of them?
Most of them, when they are detected, they are detected with early stage. Am I correct?
We still are in investigation.
I see.
We are still in investigation. So I cannot tell you exactly the values, but we know that in a group with high TICO1 value, about 3 to 5%, or 3 to 5 times higher risk to develop. About 10% of these with a high TICO1, I remember now, it's only morning. About up to 10%, maybe 50% in the high group, they develop tumor. Then we compare to those with low TICO1, and that was less, 0.2%. So this is the differences, quite significant differences.
I see.
But still, we need much more investigation. To convince doctor like you that TICO1 is a really good marker, we maybe need millions of people in big clinical studies. And that's why we are here in China, because there is a lot of people,
Yeah.
We can do it in a limited time. In Europe and in my country, Sweden, with 10 million, that would take us very, very long time.
Decades.
It's very much the case. So that is, I'm so happy to be here, because here we can do something.
I see.
Here we can do something. But we need help from people like you, doctors, to help us to run these kind of studies.
I see.
Can I go a bit backward? Dr. Le, can you explain to us what is CEA or AFS?
AFP.
APS.
Okay.
Yeah.
AFP.
AFP.
Yes,
And mostly, what stage we will use this CEA or
AFP.
AFP? Yes.
Well, these are usual what we call tumor markers, and sometimes you may find it in a normal screening protocol, for example, by the other, for example, healthcare companies. In general, we won't, as oncologists, we won't recommend to use these kind of markers as health screening. We only use it for those patients who are really diagnosed with a cancer. For example, AFP, alpha fetoprotein, would be used when the patient was diagnosed to have liver cancer or sometimes germ cell cancer. They would use it as a prognostic marker to the subsequent treatment and use it as a subsequent monitoring, for example. CEA may be, I would say, is a not very specific marker. It can be used in colon cancer, in lung cancer, and sometimes in breast cancer as well. Actually, we have many others, these kind of tumor markers found in serum, say CA 19.9, which can be used as marker for biliary tract cancers or pancreatic cancers, or say 15.3, which can be used as breast cancer marker as well. All these, I would say, in general, the sensitivity is not very high, maybe around 70%. Sometimes it can be higher, for example, in PSA, for example, prostatic specific antigen, the sensitivity can be as high as 90%, the specificity can be as high as 90%, for example. But all these, I would say, in general, we won't recommend it to use as a screening tool in healthy population. That's why I have a question. I have such a question to Professor, how we can apply our knowledge in TK1 in the health screening for normal population.
Yes. Maybe I can add something, because what you said is absolutely correct. 40 years ago, 50 years ago, there was a very, very big, people really would like to find specific marker for one type of tumor. And then they come up, you said AFP, CA, CA15C, blah, 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 you have a number of them. But finally we find out we do not have any good, very good specific marker. 25 years ago, PSA, prostate tumor, was coming up. And people started to use it in the health screening, particularly in North America, because they said, here finally we have at least one marker for one specific tumor. But then they found that people who has, we call nice tumor, benign tumor, they also could have high value, and also in healthy people. So, for example, in my country, we don't use PSA in health screening, but we can use it for monitoring when they already got a diagnosis, breast, prostate. Then these markers are used for, because then we know what type of tumor, and we can follow different example results of treatment. So World Health Organization has every year they're checking something new coming up, something new, but still not. So that's why when we started to talk, can we use TK1? I said no. It should not be possible, because people are testing so many different markers. No, not for health screening. And then we started to get the results. I said, my God, that's why my hearing like this one, because here was something really. But we are still under investigation. We need much more cases. But so far, 160,000 cases we have analyzed. And all the time we repeat, independent research group, hospital, health screening, they come to the same conclusion. It must be something there. But to convince the rest of the world, we need more investigation. But I think we can absolutely say, yes, we have something, and here we should definitely go on and check. I promise. I promise. Okay.
Yeah. And congratulations to your work. Actually.
Thank you very much. I would like to say congratulations to China, to all the doctors who cooperate with us and run this study. Thanks to the Chinese doctor who helped us. Thank you very much.
So may I ask one more question about any international recognition of TK1?
What do you as a record?
For example, in terms of guidelines or any...
Not yet. No, not yet. Because that should come from the World Health Organization and corresponding oncology society, and they are so scared to go up with the guidelines before we have absolutely 110% sure, right? And I fully understand them, but hopefully with the help from China, we can
Hopefully with
come-
more data.
Yeah, we more data, absolutely.
With more longitudinal studies,
Sure.
we
absolutely.
can recognize the value
Absolutely,
of using
yes.
CK1 in terms of cancer screening.
Because there has been so many backslash, you know. People come up, oh, now we have a good market, and people say, yeah, we have a good market. No. So now people are very, very scared, very, very, very careful before go out with a real guideline, real recommendation. I fully understand that. But personally, I'm really convinced. Because I said from the beginning, I said, no, that will not be working. Family can take one. It's just a general molecule. How could it be? But I was wrong. I have no shame to say that. I was wrong. And I hope people can understand. I don't try to push something because I would like to make money. No. This is not my business. So, take my words.
Is TK1 work for recovered cancer patients?
You mean they are
Well,
recurrence, so they have? Sure.
Yeah.
Sure. Well, and that was also very surprising, but because TK1, when people they come to you, you treat them, they take away the tumor, but in some cases the tumor coming back, called recurrence or relapse. And TK1 can start a warning months before going up, before you can see it in your imaging techniques, whatever it is. TK1 is going up. So this is a warning again. Here is a patient you have treated very well, you cannot see anything, but when TK1 started to increase, here is a warning. Check it out very carefully. So yes, absolutely. We have published data on that one. We have it.
Okay.
Yeah.
Thank you,
pleasure.
Professor Scott, and
Thank you.
Thank you, Dr. Lam.
Professor, you have mentioned before that you hope, for example, in the coming 5 to 10 years, we can eliminate cancer as one of the top killers for people. How can we do that?
We can never eliminate the development of tumor. That is absolutely clear. Tumor will be there. But with our test or similar test coming to the market, if we can discover tumor when the tumor is very small. I always do like this, you know, so people understand this is big tumor, this is very small. Then we can send them to a doctor like you, and you can take away this very small, and then the chance that they will be cured will increase.
Yeah.
Because that is very simple. If you have a small tumor which has not started to move around in the body, you know, metastasis we call it, then the chance to cure them is very good. So then the question, can we eliminate the death from tumor? Yes, it should be possible. So I'm absolutely sure. But we still need you and your colleagues to take away the very, very small early tumor. So you don't lose your job.
Thank you. But anyway, yeah.
So absolutely, yes. And this is also what World Health Organization recommended. They come with a large summary 2014. They recommended prevention and early discovery of tumor. The audits are, because they found that in the next 20-25 years, the number of new cases, tumor cases, will increase with about 70%, 70%. This is very much. So we must do something. And they said, prevention, also change the lifestyle.
Yeah.
This is very important. But also early discovery of tumor. Because then the doctor like you and your colleagues, you can take away this small tumor before it started to move around in the body, metastasis, and that will reduce the number of people who die in that cancer.
Sure.
But it's very important to understand, even if you cure them and take away, it doesn't mean that this person cannot have a tumor in the future.
Mm.
You know, we have 5 years survival. If we see if a person did not die within 5 years, we say you are cured. But it doesn't mean that you can have a tumor again. This is very important. So yes,
Thank you.
we think so, absolutely. And not only me and my colleagues, but the World Health Organization, together with the different oncology societies, together, this is what they said, recommending prevention and early discovery. Then we can reduce the number of patients who die in their tumor. And also, which is very important, reduce the cost of treatment. You know, I asked you yesterday the cost of your treatment.
Yeah.
This is very high.
Yeah.
And for example, in my country, I have experience from Sweden. Now today, we cannot give them the very best treatment, although Sweden is a very rich country, because it's so expensive. But come to you with a small tumor, you maybe can take it away one day and next day they go home.
Yeah.
Almost.
Yeah.
They don't have to stay in hospital in a bed, which costs a lot of money. It's very expensive.
And all the drugs.
Everything, and the pain. We must understand tumor treatment, I mean radiation, chemotherapy and so on. This is, people suffer. This is not very nice.
May or may not be, because we now have many advancements in terms of radiotherapy and drug treatment.
Yeah.
But anyway,
still,
yeah.
Still, I mean, you lost your hair,
Yeah.
and you have a lot of worry. Shall I be cured or not cured? Like, this is not so good.
Yeah. Anyway, I fully agree with you that early detection saves lives, just like what we did for our women in terms of mammogram screening.
Absolutely.
Yeah. I really hope that all the cancer can be found at early stages, and that means cure to our patients. Because even we have many advancements in terms of radiotherapy or different kinds of drugs.
Or your small beads.
Yeah,
that was very exciting, because you can give them higher radiation dose, which is more efficient to kill, but only specific somewhere.
Yeah, only
because the radiation today you give to the whole body.
Yeah.
But here, he showed yesterday, we have small beads with high radiation, and only that we have the tumor.
Yeah. We are talking using yttrium-90 microspheres to treat liver cancer. Anyway, we hope all these tumors can be found at early stage, and then we can do a curative resection for them, and that means cure, and that would be the best for our patients.
Yes, for the patient. And also the family. We must understand a tumor patient is not only the tumor patient who suffers, but they have a family, husband, wife, children. They live together with a tumor patient for months, maybe years. Everybody is suffering. So